and welcome to this masterclass, which will look at empowering people living with asthma and self-care. So it will focus on both the pharmacological and non-pharmacological management of asthma, focusing on the changes that were presented in the BTS Nice Sign 2024 asthma guidelines. And it will then look at the evidence and importance of negotiating the Personal Asthma Action Plan. I would like to welcome you here today, and I'm delighted to be joined by Leanne Hale from Asthma and Lung UK. As you can see, Leanne works as a respiratory nurse specialist and is co-lead at Asthma and Lung UK. And Leanne is a registered nurse and a Queen's nurse as well, and works at a senior level and is a non-medical prescriber. So welcome, Leanne, and we look forward to hearing from you later in the presentation. So who are we then from Education for Health? Education for Health is a dynamic UK-based healthcare charity. It provides healthcare professionals with the knowledge and know-how around long-term conditions. We regularly engage with over 25,000 healthcare professionals across the UK and have insights from those interactions that have helped to shape what we discussed today. And that's another reason that we have Leanne with us on this webinar. So we have over 40 years experience working with healthcare professionals to drive improvements and patient outcomes. So our clinical team are experts in workforce development and healthcare at healthcare level and through to healthcare association, through to clinician level. We have a team of clinical experts from different healthcare professional backgrounds, you can see below. And we have a board of trustees who are experts in their respected fields, and esteemed professors and consultants who sit on our clinical practice advisory board and committees associated across the whole of the UK and supporting the development of our courses. So this webinar will cover the resources available to support patients with taking ownership of their asthma management provided by Asthma and Lung UK. It will look at the evidence and importance of the Personal Asthma Action Plan as part of person-centred approach. And we will spend some time looking at the importance of the Personal Asthma Action Plan and about empowering patients to take ownership, to take responsibility, that supported responsibility for their asthma. And we'll bring it all together with some case studies at the end. So this slide is quite disturbing, really. As you can see, respiratory conditions are England's third biggest killer. It's behind cancer and cardiovascular disease. And respiratory disease affects 1 in 5 people in England, with lung cancer, pneumonia and COPD. They are the biggest causes of death. So this slide reminds us of why optimal asthma management is so very important. And sadly, the UK has the worst death rate for lung conditions in Europe. The most common causes of death from cancer are malignant neoplasms of the trachea, the bronchus and lung, and colorectal cancers, followed then by breast cancer and prostate cancer. And among the different types of cancer, the death rate of lung cancer decreased by 14.2% in the EU between 2011 and 2021. So that is a really good trajectory. So we now have the new asthma guidelines, and they have all come together and provided an evidence-based guideline with fundamental changes to how we diagnose and manage patients with asthma. More than a decade on, we are still living with the legacy of the NRAD confidential inquiry and the key finding in this report, which demonstrated areas for improvement. And the government issued a rallying cry to the nation to help fix the NHS. The Health Secretary, Wes Streeting, called on the entire nation to shape the government's plans to overhaul the NHS. And the government's 10-year health plan, which will be published in spring of this year, so imminently published. And this will be underlined by 3 big shifts in healthcare. So moving hospital to the community, moving analog to digital, and then focusing on prevention rather than sickness. We all as healthcare professionals need to be cognizant of the patient's perspective, the paradigm shift from a blue inhaler to a combination inhaler, and we must validate their concerns about giving up their blue inhaler. This is achieved by exploring the patient's ICE, their ideas, their concerns, and their expectations, and we'll talk more about that later. But we must also be cognizant of our own colleagues and their own health beliefs and perspectives, moving away from familiar prescribing decisions. Again, we'll talk more about that later. So we now have that consistent approach produced by these amalgamated guidelines, and they now also support the GINA guidelines, which were updated, and they are updated on an annual basis, and they were updated in 2024. So introducing a flexible approach to delivering person-centered care in asthma, where's the evidence for this change? This graph illustrates the onset of action for formoterol versus salbutamol. And remember, those patients are really aware of the importance of carrying their blue inhaler. And there may be some reluctance from patients and from clinical colleagues about giving up their blue inhaler. So for those patients reluctant to move away from the SABA therapy, this slide highlights a powerful message. The 2 formoterol arms, the 6 microgram and 12 micrograms, are the red arms at the top of the graph, with the change you can see in FEV1 shown on the left. And the blue line underneath are salbutamol, either 200 or 100 micrograms, and the grey line is the placebo. So if we actually want more evidence to help our patients make these changes, moving away from relying on their short-acting beta agonist, their SABA, we can then show them the evidence that their lung function increases more with formoterol than it does with salbutamol. So let's now look at the air and the low dose and medium dose MART before we go on to engaging and empowering the patient with their own supported self-management. At the moment, just to recap, we've only got 3 inhalers that are licensed for the air therapy. So when would we choose the air therapy? We'd offer a low-dose ICS formoterol combination inhaler, and the common denominator with these inhalers, with the air and MART approach, is that fast-acting, which we've just identified, formoterol component. So not all inhalers that are combination are licensed either for air or for MART. And indeed, some inhalers that have the formoterol as their long-acting beta agonist, as their component of their MART regime, might not be licensed for air. So we are invited to offer a low-dose ICS formoterol combination inhaler to be taken as needed for symptom relief. So basically, it's an as-needed air therapy. And this is recognised for people aged 12 plus with newly diagnosed asthma. And that's the important thing. Yes, we will be looking at transitioning patients who are currently on the fixed dose, their maintenance dose of ICS, maybe Clenor, for instance, and using their SABA, their short-acting beta agonist, as their reliever therapy. But we will be making those transitionary changes when the patient's asthma becomes suboptimally controlled. But for those patients who are newly diagnosed, they will now go on to the air therapy or the MART therapy, depending on their presentation. So if the person needing asthma treatment presents highly symptomatic, for example, regular nocturnal waking or severe exacerbation, we would start them on the low dose MART, the maintenance and reliever therapy. And we may, in addition, be treating them with oral steroids as well. So this is just an example of how you would prescribe the air. You would take 1 puff as needed. You can take up to a maximum of 8 puffs throughout the day, and review if needing. Most days we need to step up to MART. So the air therapy approach will not be for everyone. Some people will need to be on the MART approach, which will mean the maintenance of the inhaled therapy as well as additional puffs of their combination. So sticking with the air therapy then, we do advise patients to seek urgent medical advice if they are needing 8 or more puffs in a day, even if they're feeling better. If air inhaler is not working or is not lasting for more than 4 hours, they may be having an asthma attack. And their personal asthma action plan, which we'll talk about later, will systematically show them the sequence of what to do and when. So this is an example of the Personal Asthma Action Plan for air provided by Asthma and Lung UK. It tells your patients when they need to take their inhaler, what to do if their asthma symptoms are worse or they're happening more often, and what to do in an emergency as well. So that's the RAGD Personal Asthma Action Plan, the red, amber, green, and it clearly says with the air approach that you invite the patient to sit up straight, try to keep calm, take 1 puff of their air inhaler every 1 to 3 minutes, up to 6 puffs. And if you feel worse at any point or you do not feel better after six puffs, to call 999. And if the ambulance hasn't arrived 10 minutes later and they're not improving, we invite them to repeat the steps from step 2. And it's important that this information that we give to the patients is really clear. We don't want any ambiguity. It's really clear. This is basically your worsening statement and your safety netting. So when to choose MART? If the person needing asthma treatment presents highly symptomatic, for example, regular nocturnal waking or with severe exacerbation, then we're going to start them on the low dose MART. And as I said previously, they may also need oral steroids as part of their management. And it's worth reminding you that the low dose MART refers to the actual dose of the inhaled corticosteroid. So low dose MART and moderate dose MART will be determined by the dose of the inhaled steroid component of their combination inhaler. So this is a prescribing example of the MART. I'm not going to talk you through it. It's available in the BNF, but please remember that every time you have selected an inhaler, if you're not familiar with it, it's important to check the current BNF in case there have been any changes to the licensing. And that's an example of the MART. It provides that flexible dosing to address their symptoms. And overall, the patients, the evidence shows that moving to the MART as opposed to the fixed regime of inhaled steroid plus the SABA, overall the patient is likely to have reduced steroid load overall, lower rates of asthma exacerbation, and it reduces all those awful risks of SABA overuse. And that's an example of what to do in an emergency with the MART. Again, it's inviting the patients to take their combination inhaler and when to call for help. So what might the benefits for the patient be for the air and MART then? As we've discussed, it's potentially a lower dose of the ICS, better controlled asthma, we see that from the evidence. Reduced exacerbations, we see that from the evidence as well. It's much more convenient for the patient. It's a very simple regime, moving from air to MART and then back down to air if appropriate, or up to a higher dose of MART, a moderate dose of MART if that's also needed. So it's a very easy step up and step down. And for the patients, for those in the devolved governments where patients have a prescription charge, it's only 1 prescription charge. So a summary of the AIR and MART evidence then, if you needed to discuss this with your colleagues and of course with the patients, they need to be informed as well. With the AIR alone, the ICS Formoterol reliever alone reduces severe exacerbations compared with SABA monotherapy in mild asthma. And that came from Crossingham et al. In 2021 and repeated again with Beasley et al. In 2023. And the evidence for the MART, it reduces severe exacerbations compared with ICS or ICS LABA plus their SABA for reliever with similar symptom control. And that was provided by 2 studies again. So we do have the evidence that moving away from the SABA to this combination inhaler, either as the MART, as the AIR or the MART, is the way forward. But there are some prescribing considerations, and it's worth quickly reminding ourselves of what those are. So Sign has prescribing licensed medicines out with their marketing authorization. So some recommendations may be for medicines prescribed out with their marketing authorization, known as MA, and also known as the product license. And these might be recommended within the NICE guidelines, but we do have a responsibility as prescribers. So this type of prescribing would be known as off-label. We can prescribe off-label as long as there's an indication not specified within the marketing authority. For administration, perhaps via a different route, for administration of a different dose, and for a different patient population. And we've seen that with drugs across that may have been used for depression, have also been used for smoking cessation as well. So what do we have as professionals for our own responsibility? Generally, off-label prescribing of medicines becomes necessary if the clinical need cannot be met by a licensed medicine. So such use should be supported by appropriate evidence and experience, and prescribing medicines out with the conditions of their MA alters and possibly increases the prescriber's professional responsibility and potential liability. And that's within the Sign prescribing recommendations. We can use off-license, off-label, but we do need to be cognizant of our own decision-making. But remember, people have the right to be able to make informed decisions about their care. NICE will only recommend if there's enough evidence or experience to support it. That's why it's in the guidelines. Healthcare professionals should follow relevant professional guidance, so from the NMC, for instance, and they should take full responsibility for decisions when prescribing. That's whether the patient is being prescribed off-label or not. So off-label or unlicensed use, the MHRA also has a position, and they also suggest that we may have more responsibility when we prescribe a medicine that's not within its terms of its license, but we need to be prescribing in the patient's best interest. And there may be clinical situations when it is in the patient's best interest, and those have been expressed within the new NICE asthma guidelines. So let's move on now to supported self-management and person-centered care. And what do we mean about that? It really, at the heart of this, it's no decision about me without me. And if we can keep that in our head, that will help us guide and empower the patients. So we all are familiar with what good control looks like. So no symptoms either day or night, no asthma attacks, not using their rescue therapy, no limitation on exercise, etc., and preservation of lung function. And obviously the patient's not experiencing any side effects from the treatment. But it's important to remember that people with asthma should have the same quality of life and live life the same as a non-asthmatic person. So what factors might affect asthma control? obviously poor inhaler technique, and every opportunity, whether it's an annual review, or whether it's an opportunity that the patient is presenting for another condition, always take that opportunity to check the patient's inhaler technique. But we know that poor adherence to inhaled corticosteroids can affect control. There's lots of evidence to support that. And obviously exposure to triggers. And when we talk about the Personal Asthma Action Plan, it's important that we recognise, the patient recognises and can identify their triggers so that they can either avoid them, or they can reduce their exposure, or there can be some sort of supported help in order to help them to cope with their exposure to their triggers. So it's interesting to see that factors that may affect asthma control, how the air and MART approach may factor into this in order to improve that asthma control. So why do patients have asthma control? It's usually multifactorial. It's not always necessary to step up treatment to gain good control. It might be that they've got poor inhaler technique. So before we ever make any pharmacological changes, it's really important that we always look at those modifiable changes. So have they been taking their inhaler? So if they're on the MART regime, have they been taking their inhaler? Do they have good inhaler technique? Have they been exposed to new triggers? Or they've now identified triggers that they weren't aware of before. So it's always important that we look at this. And maybe moving forward with the air and MART regime, looking at that poor prescription pickup rate, if we can advise the patient of the onset of action of formoterol and the improvement in that lung function we saw at the beginning, that improvement in their FEV1, maybe we can talk to the patients about the importance of using their air, because each time they do, they'll get a very small dose of inhaled steroid that will help dampen down that inflammation. So we will move away from that overuse of SABA inhalers. Because we know the consequences of poor asthma control and poor adherence. It's estimated that up to 50% of patients have poor adherence to long-term therapy. And it's well documented that those with adherence rates of at or more than 80%, they have better outcomes. But if this is the case, why do we think patients' adherence is so poor? And sometimes patients may not deliberately not adhere to their therapy, but it may be inconvenient for them. That's why the AIR approach is so important. It's that flexible approach to their management. So how can healthcare professionals identify and improve? So this is about that supporting that patient. It's about empowering that patient. It's important to build relationships. It's important to recognize our own attitude and beliefs, making sure that we don't impose any of them, and we conduct ourselves always in that professional way. So if we have any prejudices regarding how a patient might be presenting or talking to us or communicating with us, we have to always recognize that what might be driving those behaviors for that patient. We don't know what happened to that patient before they came into our consulting room. There may have been all sorts of things that patient is trying to manage. And that's why in a moment we'll talk about ICE, ideas, concerns and expectations, because until we've tuned into those, we really aren't going to be able to engage with that patient on that one-to-one in order to optimize their asthma control and any comorbidities. So let's look at some techniques to empower the patient. How can we facilitate change and empower the patients with asthma? So supported self-management then, it's an ethos of person-centeredness within a context of that partnership approach. It's not me ever telling the patient what they need to do. It's about me engaging with the patient, understanding what they want, what their needs are, and how the evidence can support them. So people are the primary decision makers. When it's supported self-management, people are the primary decision makers about the actions they take. And people with any long-term conditions are in charge of their own lives and self-management of their conditions. They may touch base with us once every 6 months, once a year. If they're having an asthma attack, they are managing their patients. And that's why people like Laura, who are working with Asthma Lung UK, are there to support these patients with the resources and clinical support that they can offer as well. So patients are much more likely to act from decisions they make themselves, excuse me, rather than decisions that are made for them. So practical tips then. Support people to enable them to identify their own information needs. What are their goals? What are their action plans? Support people to make more effective problem solvers as they live day to day. So they might negotiate what's important for them that day. Understand how this requires a healthcare professional to learn new skills as well. So we need to learn how to negotiate. We need to learn how to communicate. We need to learn how to recognize a body language that might be saying something different to the words that the patient is expressing. So it's all about demonstrating that shared decision making and health coaching as well. So what do we mean by effective communication and empowerment? We know that effective communication enhances patient satisfaction. We know that it helps to build rapport between the patient and the professional, between the patient sitting with me and me as that healthcare professional. So the patient is more involved in that decision making. It leads to more accurate diagnosis. It leads to more realistic expectations. We'll talk about ICE. Better patient adherence to treatment, and the patient is more open to seeking further care. So I'd like you just to stop and reflect and maybe think about an encounter you may have had as a patient with another healthcare professional in the past. It might be last week, last year, 20 years ago, that didn't go so well for you. So what was it about that consultation that didn't work for you? Was it the person didn't seem to be listening to you? Was it they were listening, but they didn't hear what you had to say? They weren't validating what you had to say? Was it they didn't seem to be engaged with what you had to say? Or was it they didn't seem to know what they were talking about? All these things will influence our behavior towards the professional, and that's something that we have to be familiar with. So let's look at ideas, concerns, and expectations. It comes from the Pendleton et al. Consultation model. And it's about recognizing the importance of identifying what the patient's ideas, their beliefs are. Because unless we know, how can we support change? Unless we know what's important to the patient, what their preconceptions are, what information they've either got from their friend or their neighbour. How many of us have had patients who've said to us in the consulting room, Julie, you've talked about asthma. My neighbour's got asthma. My asthma's nothing like theirs. So unless we know what their ideas are, we're not going to be able to fully engage with them. So ideas, we can open the conversation, such as, tell me about what you think is causing it, or what do you think might be happening? So try and gain an insight into the patient's ideas. And the lovely one I like at the bottom here, you've obviously given this some thought. It would help me to know what you were thinking it might be. So get the story from the patient. And then looking at the concerns. So what are you concerned that it might be, especially if it's a respiratory condition other than asthma, perhaps, if you've got somebody who's been a lifelong smoker and they've now noticed this cough. Is there anything particular or specific that you were concerned about? Try and find out what the patient really wants to know before they leave that consultation. So another one, so in your darkest moments, what are your concerns? So you really are trying to engage with that patient. So looking at expectations. So what are you hoping we might be able to do for this? Meeting those expectations. We don't want the patient to, so for COPD, I use that as an example. If this inhaler is going to cure my COPD, it's about meeting those expectations. And again, this question might seem a bit like the one I put with ice, but this is about expectations. You've obviously given this some thought. What were you thinking would be the best way of tackling this? So meet them, and then you can manage expectations. Are they realistic? We can use the asthma control test. So it's the ACT. It has those lovely 5 questions regarding aspects of asthma control that are relevant to the patient. And I use that all the time when I'm seeing a patient. And I also use it as part of their personal asthma action plan. So I'm enabling the patient, I'm empowering the patient to recognize when their asthma is deteriorating. So I will say to a patient, if your ACT scores less than 20 on X number of occasions, and that would be negotiated, that's the time when you either need to do this in the amber section, or you need to see me, or you're having an asthma attack. So it's the amber section of the personal asthma action plan that gives us that flexibility to make it so personalized. Because the red is you're having an asthma attack and this is what you need to do. We don't need to make it complicated. We need to keep the patient safe. So let's look at person-centered care and negotiation then. All patients want to be listened to, and all patients should be listened to. It involves a conversation or a series of conversations between a patient and a clinician when they jointly agree on goals and actions for managing their health. And patients' goals in managing their condition, they may differ from ours as the professional, but both are important. And unless we know what they are, so when I was working in pulmonary rehab, I needed to know what the goal was for that patient after they had completed their pulmonary rehab course. So the NHS mandate promised that anyone with a long-term condition would be involved in their personal care and their planning. So it's the core of person-centered care. It's about values, it's about communication, relationship building, it's about engaging, enabling, and managing that high complexity and significant risk. Patients are all different. They all have different personalities, different expectations, different histories, different things that happened to them before they came in to see us. So what is it that's driving that behavior? And of course, that's why you're here today. It's about developing the workforce to enable them to take on that person-centered care. I bring this up. Yes, it was nearly 11 years ago this May, but it still has a legacy. We still need to know what these findings were from that forensic examination of those patients who had sadly died. And the information was gathered from lots of different services, primary, secondary, tertiary, ambulance, all services engaged. And there were lots and lots of key findings that we as healthcare professionals really need to be cognizant of and really need to adapt. But one of the things they talked about all this time ago was the importance of patient self-management. Unless a person knows what an asthma attack is and their asthma is deteriorating, because lots of us have had patients in who have said they think that asthma is perfectly well controlled, and yet their ACT is around 17, 18. So unless they know what good control is, that's where we explore their ICE, their ideas, their concerns, their expectations. So an asthma action plan should be designed to be a clear and practical set of algorithmic instructions with those eye-catching and distinct features to facilitate that patient's understanding. It doesn't need to be complex, and that's why the asthma action plans from Asthma and Lung UK are really valuable, because we've got the air, the MART, we've got the traditional, we've got the children's, and they absolutely take you through that red, amber, green, and you've got that flexibility in the amber to engage with the patient. So as the supporting evidence then, Pinnock, this was back in 2017, Pinnock et al. Actually undertook a meta review of systematic reviews updated from RCT, so really high level trials, high level research. And they looked at a total of 27 systematic reviews, and it revealed that supported self-management can reduce hospitalization, accident and emergency attendance, and unscheduled consultations. And it also improves the marker of control. So if ever we needed more evidence that every patient should be offered a personal asthma action plan, here it is. So this is an example of the traditional PAP, the traditional personal asthma action plan. It's designed to be that easy to refer to self-management tool, no ambiguity in it. This is what you do when, this is the worsening statement, and this is the safety netting. So let's bring all this together now with looking at a case study where we think that air might be appropriate. So we have Akash. He's 26 years old and he works as an accountant in an office. He's never smoked, his partner's never smoked, and he wasn't a passive smoker when he was a child. But he's using his blue inhaler pre-exercise, or if he gets a viral cold, but he's normally fit and well. So he's only using it when he plays his badminton or squash. His FeNO level is 9, so that's low. His ACT score is 23, slightly down, but that's because he's using his blue inhaler. Now remember that the guidelines now say no one should be on a blue inhaler alone. So we will come back to Akash a wee bit later. So if we look at the pharmacological treatment options for young people and adults aged 12 and over, SABA-free pathways are preferential to reduce the risks associated with SABA overuse. So no longer are patients who are newly diagnosed put onto a SABA regime. So the SABA-free options include the anti-inflammatory reliever, the air, and also the MART. But as I've said, only certain inhalers are licensed for that reliever. None should be prescribed a SABA only, and at the moment Akash is on SABA only. So this comes from the guidelines: do not prescribe a SABA to people of any age with asthma without a concomitant prescription of ICS. The emphasis for management now focuses on a SABA-free pathway, and that's why they've introduced the air and the MART. So if we come back to Akash then, air therapy was agreed. Why? Because he had good control, his FeNO was low, and the sign guidelines define, BTS NICE sign guidelines define uncontrolled asthma as any exacerbation requiring oral steroids he didn't have, or regular use of his reliever 3 or more times a week. He wasn't, he was using it twice, nighttime waking 1 or more times a week, and he wasn't. I'd like to just put a caveat, and that's why I've used Akash as our exemplar for this case study. If somebody is using their blue inhaler pre-exercise, don't just park that. Please look at it. Please look at it, and why? Because in the past, someone like Akash may have been advised, look, if you know exercise is a trigger for your asthma, take your blue inhaler beforehand and you should be able to exercise. But we also know that exercise-induced asthma may be a sign of poorly controlled asthma. So we would want to, in essence, Akash fits the air therapy. But please identify, is he taking that blue inhaler because without it, he can't perform his exercise? So are there other things going on? We know his FeNO is low, but that might be because he has maybe had some sort of he may have a different phenotype of asthma. It may also be that his ACT, don't forget, that's his perception of his control. Maybe he has not maybe recognized that those symptoms that he have, they might be normal for him, but they're not normal for us as healthcare professionals. So I'd just say to you, don't assume that people, if he's using his blue inhaler pre-exercise, I would just examine that. And this is a lovely algorithm which demonstrates where air sits. You can see here that existing diagnosis of asthma on the treatment pathway recommended previously by the guidelines. If they're on SABA only, we're going to put them onto the air regime. So if we've got somebody whose initial diagnosis, we know that there's only 3 inhalers that are currently licensed, but we have talked about the facility to prescribe off license with the caveats that we have explored. So before I hand over to Leanne, we're now going to look at the case study, which might invite Mart. So Anya is 42. She works in a school as head of science. She's never smoked either. She has 1 cat and her FeNO is 30. So she is showing a slightly higher level of inflammation. So we know that she is diagnosed. So we're not looking for that diagnostic criteria. So that would be FeNO over 50. So we're not looking at that. What we're looking at is her level of inflammation. So it's showing intermediate at the moment. Although she's never smoked, you would want to inquire, does she live with smokers? Has she been a passive smoker? Because she's over the age of 35. So you just always think when you're talking to patients, always think differential diagnosis. New things develop, new diseases, new illnesses happen. So don't lose sight of that when you're taking a history. However, going back to Anya, Anya's ACT score is 18 because she's using lots of her blue inhaler. She lives in town in the middle of England. And when we had a conversation with Anya, she lived right in the middle of England. She used to walk to the school along a very busy road, lots of car exhaust that she was exposed to. She normally has been prescribed her Clenil 200 micrograms, 1 puff twice a day, but her medical history actually shows poor adherence with that, but she is symptomatic. So when to choose Mart? If the person needing her asthma, their asthma treatment presents highly symptomatic, so regular nocturnal waking or severe exacerbation, we need to start her with her low dose Mart. She was using her blue inhaler at least once a day, and she did actually admit that she had woken up at night as well. So we would start her on the low dose Mart, and we already know that that refers to the actual dose of the inhaled steroid. And that is a prescribing example. But I always say, please check your current BNF and also your local formulary to find out what's on your formulary and what's available for you as well. However, if people 12 plus are not controlled on moderate dose Mart, despite good adherence, check the FeNO level if it's available and blood eosinophil count. And if either of these is raised, they might be a type 2 high phenotype of patient. And we know that there are lots of patients who actually fulfill the criteria of severe asthma as opposed to difficult asthma. So we know that we need to find these people. So difficult asthma is patients who present highly symptomatic, might be on high doses of inhaled steroid and lots of other things, but there are often modifiable changes, i.e. they're not taking their inhaled steroid regularly, they're exposed to lots of triggers, they've got suboptimally controlled comorbidities, for instance. So there's lots of modifiable things. With severe asthma, that's a definite phenotype, and these patients, despite all the things that we can do as healthcare professionals and they can do for themselves, they have still got poorly controlled asthma, and these patients may benefit from a biologic. So we need to get them into our secondary care colleagues, can do that exploration, do the appropriate investigative tests, and then decide on future management. But if neither the FeNO or eosinophil count is raised, we could consider a trial of an LTRA or a LAMA. And remember, the LAMA that is licensed for asthma is the Respimat. But also remember the MHRA guidance. If you are going to prescribe a leukotriene receptor antagonist, you must inform the patient of possible consequences of the LTRA, such as development of psychological conditions, OCD, they might have nightmares. So do look at the MHRA evidence regarding LTRA and appropriate advice for the patient. Remember, no decision about me without me. We also know that GINA, so we're now aligned with the GINA and their preferred track, and GINA has the air as their anti-inflammatory reliever right the way through their preferred tracks, whether it's step 1 to 2, that would be air only, or whether it's preferred track steps 3 to 5, that would be MART, but using their combination as their reliever. Even as far back as 2019, GINA made groundbreaking recommendations about the use of the anti-inflammatory reliever. And that's just, I thought that might be helpful. So you can see the preferred track, and that's the air as needed ICS for Motril, and then going up to step 3, 4, 5, but right the way through, running right the way through, is the reliever as needed low dose ICS for Motril, not SABAs. So we've had a look now at empowering patients. We've had an overview, a reminder of the AIR and MART regime. I'd now like to hand you over to Leanne from Asthma and Lung UK, who will explain about the amazing resources they offer for patients as a healthcare professional.
Thank you, Julie. And as Julie has expertly covered, as healthcare professionals, we know that effective asthma management goes beyond prescribing medication, and that it's more about empowering our patients to take control of their condition. And hopefully that's where Asthma and Lung UK comes in, because our charity provides tools and resources to support both healthcare professionals and our patients in delivering and practicing self-care. Next slide, please. So I'd like to introduce you to our Healthcare Professional Hub. And this is designed for healthcare professionals as a one-stop knowledge bank. And it has guides on it to things about diagnosis, management, performing reviews across a range of lung conditions, not just asthma. It also, you can find on there our latest reports on our work and use our respiratory dashboard to find out how your local area is in performing in terms of respiratory care. And the Healthcare Professional Hub isn't really just about clinical guidance, though. It's also about ensuring we have the right tools to engage and educate our patients effectively. And so here you can also find links to our health advice leaflets, such as the asthma plans, which Julie has shown throughout her presentation, and other health advice leaflets for patients. And you can access it easily via the QR code on the slide. Next slide, please. So we don't just have our Healthcare Professionals Hub, though. The main body of our of Asthma and Lung UK's website is about is for about patients. And so Beyond the Healthcare Professionals Hub, it's a really good resource. It provides a wealth of information to help people living with asthma take control of their condition. And again, we also cover all lung conditions. So our website has comprehensive health advice on it, covering everything from asthma symptoms, triggers to treatment options in easy to read language for our patients. We also have patient-friendly guides and videos, and our inhaler technique videos are really popular. And we also have some interactive tools on there as well. In addition to our helpline, to our website, sorry, we also have the Asthma and Lung UK helpline. And this is a dedicated helpline which is staffed by healthcare advisors and a clinical team as well. So our non-clinical team cover things such as benefits advice. If people are having problems with housing, such as mold, things like that, they can offer advice on things on those kind of topics. And our clinical helpline team covers, we have a range of respiratory nurses, a physiotherapist and a dietitian. And it offers patients personal advice, and we see it that we work alongside our healthcare professionals who are out there, in running clinics, because we can spend long, any amount of time really talking to all our patients and educating them on managing their asthma. We also have a WhatsApp service that patients can use. And I must also say that our helpline and our WhatsApp service isn't just for patients, it's also for healthcare professionals. And we also have support groups where our patients can register, and these can be online or face-to-face. And so I think by incorporating Asthma and Lungs UK's website and helpline into our patient education efforts, we can ensure that individuals with asthma feel informed, supported and empowered to take control of their health. So I encourage you to explore our resources available. Thank you, Julie. Oh, you're muted. Sorry.
Sorry, Leanne, sorry.
No worries.
I'm going to go back to that slide because some people might be wanting to copy that down. Wasn't that a wonderful overview of the resources available from Asthma and Lung UK? I can remember through COVID, signposting patients to the videos and how to use their particular inhaler. And it was like a breath of fresh air, Leanne, to hear you talk about. You have people there who can help other people who need help with engaging perhaps with social services or social enterprises in order to help them with exposure to mold. We've seen those awful case studies where people have died because of poor housing, and to know that there are people available who can help us help patients to improve their lives and improve their outcomes. So Leanne, that was amazing, and thank you very much, and thank you for your time today. It's much appreciated. And
Thank you.
thank you, Leanne, and thank you everyone else for joining us today on the webinar. I do hope you have found it helpful, and please engage with Asthma and Lung UK. I use them all the time, and I'm not just saying that, I genuinely do use them all the time. So thank you very much indeed. Thank you. Bye-bye.